Hello, my name is Deborah Cohen, and I am the MAVEN Project volunteer moderator today. Thank you all for joining us today, and our friends at La Clínica de la Raza for hosting this session, Abnormal Uterine Bleeding with Dr. Jan Herr. Let me tell you a little bit about her. She's a board-certified OBGYN who retired from Kaiser Permanente in San Rafael, California after 33 years in practice. Her focus in recent years has been midlife, women's health, and minimally invasive surgery, the latter of which she assisted in until very recently. She was the KP Northern California lead for midlife women's health. She also worked to get the RotaCare Free Women's Clinic in Richmond, California off the ground and volunteers as both a clinician and advisor. And with that, Dr. Herb, please begin.
Okay. So today I'm planning to talk about abnormal uterine bleeding in adult women, reproductive age, and up to the age of menopause. And I have no disclosures, and you all know about the credits. The objectives for today are to determine when a woman is having true abnormal uterine bleeding, to recognize when imaging and biopsy are required for abnormal uterine bleeding, and to employ evidence-based treatments for successful management of AUB. And I'll mostly say AUB since it'll take up less time. The blueprint for today, we'll start by defining abnormal uterine bleeding, considering the non-uterine causes that we want to rule out, go over the relatively new cone classification system and the management of abnormal uterine bleeding, and use a couple of cases to demonstrate how I think through these situations. And at the end, you'll find the resources. I'll also go over a summary at the very end of my talk. So the first patient is 38 years old and a gravida 1 para 0. She uses condoms for contraception and comes in complaining of bleeding 2 to 3 times a month for the past 6 months. It's variable in amount and duration, but never heavy. She previously had periods every 3 or 6 months for the past 3 years. Past medical history, she was recently diagnosed with type 2 diabetes and hyperlipidemia. She doesn't take any medications. She drinks beer nightly, about 2 on weekdays and up to 5 on the weekends, and is a half a pack a day smoker. She works as a housekeeper and does not do any aerobic exercise. Other things I'll mention is that she doesn't have any cramping or breast tenderness. It makes me think she's probably not ovulating, but we'll get to more about that later. So important questions to ask, and these I've given you almost all of this information for this patient, but I want you to have a more general list that you can apply. I'll mention 1 or 2 additional things about our patient as we go along. So, description of the current bleeding, both the volume and the duration. So about volume, I'll just say that, and I'm sure maybe everyone already does this, using the number of tampons or pads changed in the last 12 to 24 hours can be helpful in giving us a sense of how much bleeding there is. Are they saturated? Are there clots? If a woman is having heavy bleeding, typically she'll change pads or tampons a minimum of once every 3 hours. And of course, you can ask, are they extra large, or are they, the smaller tampons, just to give yourself more of an idea. And if they're describing clots that are greater than an inch in diameter, which is about 2.5 centimeters, these are generally associated with great deal of blood loss, more than the defined 80 milliliters. Then thinking about menstrual melemina, contraceptive history, associated symptoms that might make you think it's other than uterine, such as urinary symptoms or vaginal discharge. Pain is less clear. Normal menstrual pattern that she's always had prior to this time, history of infections, trauma and sexual assault history or current, and any chance of pregnancy, and her OB history in a little bit of detail. Then also thinking about comorbidities or iatrogenic causes of bleeding is necessary. So some of the serious issues such as severe liver disease or renal disease, we want to think about bleeding diathesis. In general, this issue would only show its face in the beginning. I mean, if a patient's going to have severe menorrhagia, excuse me, see, I said menorrhagia. I'm going to tell you later that we're not supposed to use that term anymore. But if she has heavy uterine bleeding, then it might be because of bleeding diathesis that has not yet been diagnosed. So she might have bleeding gums, excessive bleeding with dental procedures, or cuts. Then the other things to think about, of course, is if the patient is taking any anticoagulants, using contraception or hormones, chemotherapy, recent severe COVID or COVID vaccine can temporarily change a menstrual pattern, and substance abuse. And in our patient, she has no other substance abuse beyond the cigarettes and alcohol.
Excuse me, Jan, could you go back one slide and define menstrual melemina? There's a question.
Oh, so sorry. Meaning things associated with bleeding, like cramping. So that sort of thing, or breast tenderness, headache, things that make you think, okay, this happens every month to her. That sounds like cyclic symptoms associated with menstruating woman. This woman doesn't sound like she's menstruating.
Thank you.
Yes, thank you. So moving forward, the other interesting thing to think about is, has the patient had any previous OB or GYN surgery? And something that we're only really recognizing fairly recently is the phenomenon of a cesarean scar defect. And that'll be more common in women that have had multiple C-sections, and generally is irregular light bleeding. But if you're not going to go down this path early on at all, but it's a good thing to have in the history so that it could be considered if the usual culprits don't seem to be the problem. So also thinking about GYN surgery, cryomyomectomy, if the patient's been treated before for cervical neoplasia, there could be an ongoing problem related to that. And rarely an arteriovenous malformation can result from uterine surgery. So these are all things that most likely you're going to be passing along if you're a primary care practitioner to GYN, but having the history will be useful. So in this first case, the first thing on the exam is, of course, important. Is this patient vascularly stable? Because if not, she needs to go to the ER. This patient was, and she has a BMI of 31. And there are a few findings here: mild facial hair growth and mild acne. The abdomen is obese, non-tender, no masses were palpated, There's a little bit of blood and no lesions on the speculum exam, and the pelvic exam is limited because of body habitus, but no clear abnormalities were palpated. And in a general way, the pelvic exam is important because it may help you with the source and the volume of bleeding if the patient is currently bleeding, um, and if it's ongoing. And if the patient is talking about present current heavy bleeding and you don't see any blood in the vagina or coming from the cervix, then you're going to start to think, gee, this might not be GYN in origin. Clinicians should also assess for foreign bodies, signs of trauma, products of conception, vaginal or cervical discharge, urethral polyp, other abnormalities, and the uterine size and surface contour, if you can appreciate that on exam, might suggest fibroids or an adnexal mass. You could also have tenderness that you might be feeling, cervical motion tenderness or abdominal tenderness, adnexal tenderness. If the source of bleeding remains unclear, you might want to do a rectal exam and check for hemorrhoids, blood in the stool, or other non-gynecologic, reasons for the bleeding. I don't know if I mentioned peritoneal signs yet. They could be present if there was active PID. And a hemorrhagic ovarian cyst might also have peritoneal signs, as could a ruptured ectopic pregnancy. Urinary etiology should be considered. And again, if you don't pick up anything on that GYN exam, you're going to want to think about those etiologies. So in this patient, is the bleeding from the uterus? Well, sort of the little checkoff list would be, could it be cervical, an infection, neoplasm, abrasion, laceration? Could it be vaginal from erosions, abrasions, laceration, which could be due to trauma or use of sex toys that might have caused laceration or lesions. And then also, could it be rectal or could it be urinary? And in this case, pretty clear, it seems urinary, and I'm sorry, uterine as the source. So now thinking about the recommended terms. So the Federation International of Gynecologists and Obstetricians, or Gynecology and Obstetrics, came a number of years back now, I'd say probably 7. And that's an estimate. It's actually, there's a reference on one of the slides. It came to the conclusion that we needed better words to describe the terms, and to stay away from the terms like I slipped and used, like menorrhagia, polymenorrhea, hypermenorrhea, oligomenorrhea, dysfunctional uterine bleeding. Why? Because they're vague, they're difficult to interpret, and it's hard to, if we write them in the chart, it's hard for colleagues to know what we're talking about. It's also difficult when trying to do studies, which is a big part of the issue here. We want to learn more about what we can do for patients. We need to all be on the same page. So this list goes through all of that and encourages us to think about the regularity, the frequency, the volume, the duration, the irregular non-menstrual, or the bleeding if it's out of reproductive age. And also to think about, for volume, you want to take into account what the patient says, because really, whether it's 80 milliliters a cycle or not, what really matters is it affecting the patient's quality of life? Is this too much for the patient? And if so, it has to be taken seriously. So in this case, the patient would fall under the irregular bleeding. Um, and so you see under regularity, irregular menstrual bleeding is the first category. Okay, I'm thinking that's the first thing I'm going to write in my note, that she has irregular bleeding. That the definition, just so that you are aware, it does vary a little depending on the age of the patient. So, cycle variance, meaning from day one of one menses to day one of the next menses, is 7 days. If it's more than 7 days, it's considered to be irregular, and that's for the 26 to 41-year-old age group. But on either end, so 18 to 25 and 42 to 45, the variance is 9 days, so it's more permissive. Um, and I think that that is all that I need to say about that. The other part of this whole change in the way we look at abnormal bleeding is the Palm-Cohen classification. And this is a very interesting way to look at things, and I think it is helpful. But again, it's also helpful when trying to figure out new therapies and approaches to treating abnormal bleeding. So you go down the list, and first, okay, we've got abnormal bleeding and we've classified that. And then we're thinking, is it due to a structural cause, or is it over on the other side, on the right side, as non-structural causes? And in this patient, the non-structural is probably the AUBO, which is the AUB due to ovulatory or anovulatory issues. And in her case, it's probably related to PCOS. Um, so I'm not actually going to go into that a lot more, the PCOS, other than I will mention some about the labs that you would order. There are two excellent talks on this. One in adult women that Dr. Lister and Sidor presented, and another one that our own Dr. Deborah Cohn was also involved in addition to the other two speakers, that's about adolescent PCOS. And I encourage you to look at those. They're on the MAVEN site, the recordings, and they're extremely helpful. So when we're thinking about all this and what we have to do next, I also want to say that a reproductive age patient, if they've had one isolated bleeding event and they're not hemodynamically unstable, or feeling from their point of view like something has to be done, we might just ask that patient to keep a menstrual diary and return. But if the patient were to be postmenopausal, even though that we're not mostly talking about that today, I want to emphasize that those patients, it needs to be considered abnormal, even one spot of blood. You have to figure out where it's coming from. So before we go forward more thinking about treatment, just to mention the ovulatory cycle, which I'm sure everyone is well aware of, but to think about how that will change if a patient doesn't ovulate. So it's if that mid-cycle spike does not occur of the FSH and LH particularly, you won't get ovulation, and that's where we can get into all these other variations on the theme. So if there's no progesterone, then the endometrium will continue to proliferate, and it won't shed on a schedule because isn't going through the second half of the cycle. And the patient will have a fragile endometrium that bleeds erratically. and that's where the irregular bleeding comes from. And it isn't always PCOS, but unfortunately, in many cases, it is PCOS that's behind this issue. So the next steps on this patient would be to perform an endometrial biopsy, and also to order some labs, including a urine HCG if it hasn't been done already when the patient came into clinic, to do the cervical cancer screening if it's due, to do the cultures for GC and chlamydia if indicated, to check thyroid, prolactin, and CBC. And I would add on this patient an FSH and a total testosterone and the 17-hydroxyprogesterone to try to further define what's going on. And then I want to just mention that generally a transvaginal ultrasound, for the sake of looking at the endometrium, is not going to be helpful. It's not specific enough. The thickness varies depending on part of the cycle. It's only useful in postmenopausal women. So that's important to know. Now, there are other reasons why you might decide based on your exam or lack of ability to do an exam potentially that you might want to have an ultrasound, but it shouldn't be in trying to take the place of an endometrial biopsy. So, assuming the pathology comes back benign, the treatment approaches, and I will go over this in a few different ways during my talk today, but this is the first time around, it would be progesterone IUD, which can be really great because it protects the endometrium, and it will, over time, there might be spotting or irregular bleeding in the beginning, but it will take care of all the bleeding in most cases. The combined oral contraceptives, which I've abbreviated as COC, if they're not contraindicated, this patient would not be a candidate for that. Nexplanon, depo, medroxyprogesterone acetate, or oral medroxyprogesterone acetate if the patient declines the other approaches. And that could be done if the patient doesn't have her own spontaneous menses. She could take that medication every 3 months. You could also use a progesterone-only pill, but it's less likely to resolve, a little less likely to resolve the problem. You're more likely to continue to have breakthrough bleeding, which the patient will not be happy with. And then, of course, counsel regarding weight loss and exercise. So, unless there are burning questions, I'd like to continue through the second case. But Deborah, are you seeing any questions that you think I should stop and answer now?
I don't think we have to answer them right now.
Okay. So the one other thing I'll say here is if the patient didn't require an endometrial biopsy, the treatment would be the same. Empiric therapy would be the same treatment. And at any step along the way, if the patient is bleeding too much, you're going to send them to the emergency room. Or if they call back and they're not responding, they might need to go to the ER. So you will always give that patient a review of when they would need to be seen in the ER. And then, of course, a whole other series of options would open up, but I decided not to focus on that today because that isn't what you'll be dealing with. So here's the second case, and this is a 54-year-old female para 2 who presents on the third day of her menses with heavy bleeding, gushing on and off. And her previous menses was about a month ago. She has regular menses, but her menses have been heavier with more cramping for the past 2 years, and she is noticing lately intermittent malodorous discharge as well. So the speculum exam immediately reveals that there's something probably going on structurally. Her endocervical os appears kind of dilated, and you can see this bulge at the not coming through the cervix, but a smooth surface that looks like something's trying to work its way out of the external os. And the uterus feels firm and about 6 weeks in size and non-tender. And all of her medical, surgical, and social history was negative, conveniently. So the next step with her is going back to exactly what I said before. Think about the recommended terms. What are you going to put in the chart? And in this patient's case, she is regular. There's no problem with frequency, but under volume, you've got heavy menstrual bleeding. And so that's it, HMB. Everything else is not an issue for this patient. So then, okay, we'll use the second part of the FIGO recommended classification. And in this case, now we're on the left side, which is what I obviously wanted to demonstrate, that you'd start thinking, gee, what is this thing that I'm seeing that's causing the os to look dilated and feel dilated? And that would be either, most likely, I'd say is probably a leiomyoma, so AUBL, could be a polyp, AUBP, or could be a malignancy or something pre-malignant hyperplasia. And at some point, we might be doing an ultrasound, although in this patient, I don't think we need it at this point in time. We are going to have to deal with that polyp or fibroid that we're looking at. So we call it most likely AUB leiomyoma submucosal is what I would say it's mostly going to be, but you can be fooled. Even when we take them out hysteroscopically, we can think a polyp's a fibroid and a fibroid's a polyp. So if we were to remove this uterus, which I want to emphasize shouldn't really have to happen, but if we were in the old days, like we did much more often, this is what it would look like. So that's why it's down by the os, down here. So that's what we're seeing and feeling, but it hasn't made its way through the os yet. So the management in this case, the fibroid was resected as an outpatient. Sometimes we can do this in the office, depending on the office setup, or in a surgery center. Sometimes it's the OR, but resection should be possible. It should be a very satisfying case. For fibroids, the fibroids that are going to be making the most likely to be making us or the patient trouble would be submucous, either poking out as a submucous fibroid, or completely in the endometrial cavity, or coming out through the cervix. So those are the fibroids that you're most likely going to hear problems with abnormal uterine bleeding. Occasionally, the ones that are in the wall, especially if they're keeping a patient from the uterus from contracting and helping to clot off those spiral arteries in the endometrium, you might, in those cases, also have a patient that presents with abnormal bleeding, but it's much more the ones that are in a submucosal location. So in terms of office management, again, very important to assess the hemodynamic stability. If you have a way to check a hematocrit in the office, great, or get that lab stat. And consider the role of tranexamic acid for temporarily increasing the clotting. Start the patient on iron as an outpatient, and then refer for the diagnostic hysteroscopy and possible resection of a myoma or a polyp. If it was going to be not too long and the patient had a lab that was stable and was hemodynamically stable, then you might consider starting a progestin just to try to cut down on the bleeding. But really, this is not going to solve this problem. So entertaining whether the patient needs to go to the ER so that she sees a GYN in a more urgent fashion is going to be seriously considered. So if a patient comes in and she has heavy uterine bleeding, but she doesn't have an apparent etiology, then you treat it the same way in terms of a non-structural bleeding. You'd assume, you'd start by saying it's non-structural, and then only go to working it up more if that didn't work. So again, a biopsy, the treatment with a progestin of one type or another, considering placing an IUD, a progesterone IUD right then and there or at a future appointment. And if that's declined, then progestin in another form, the depomedroxyprogesterone acetate, Nexplanon, or oral contraceptives if appropriate. And again, considering the tranexamic acid. And I think if the patient is not ovulatory, then you could specifically focus in on the ones that I listed here. And then the other thing I just want to mention is that this is a list of when a biopsy should be done postmenopausally. Definitely, although sono can be done instead. But if you do order a sono and it shows more than 4 millimeters of thickness or some sort of abnormality or question of abnormality, you're going to have to get a biopsy done. And between 45 years old and menopause, if there are less than 21 days between a start of one menses and the next, or bleeding for more than 8 days, biopsy. And then under 45, if they have a high BMI, or if the BMI is lower, but the patient has a setting of unopposed estrogen, either because of not ovulating chronically or because of taking estrogen, or if the medical management isn't working, or if they have a high-risk genetic mutation. Those would be times when we'd be biopsying women that are under 45. And always think about patients that have come to you and they haven't had a period in years, or basically more than 6 months. You have to think about, is this a neoplasia, and at what point should you be really worrying about that and sampling the lining. And I'll just mention that CDC and UpToDate both have good algorithms for adjusting contraceptives and treating for breakthrough bleeding with contraceptives. And we're not going to go through that today, but it's really good to know where to go for that. So this is just a summary slide and doesn't say anything that I haven't said before. To think about describing the bleeding, assessing stability, taking a good history, including a surgical history, examining, and then start to classify. If you think it's from the uterus, the bleeding, try to classify it and consider the differential diagnosis using the Palm-Cohen chart. And then think about an endometrial biopsy, maybe a sonogram, or a hysteroscopy referral. and also otter labs that I've talked about before, but they're again summarized here. Always think about the fact that it could be pregnancy or an abnormal pregnancy. And then treat hormonally if indicated, and evaluate for a structural problem if what you have treat with medically doesn't solve the problem, and that there might be a place for a saline infusion sono rather than going right to hysteroscopy. But hysteroscopy would be the other option here, so that would be referring to a GYN for consult. And then I have resources here that these will be sent out to you afterwards. And I will stop here so that I can spend a little time on questions.
Oops. Thank you so much, Dr. Herr, for that very clear and practical talk. I really enjoyed that, and I learned a lot myself. The first question that we have is, do we still use the terms primary amenorrhea and secondary amenorrhea?
Good question. Yes, as far as I know, unless my colleagues that are on this call know something I don't, that I would call it, I would still classify it that way.
Okay, great. And Dr. Lister has a comment, I think, in respect to your statement that transvaginal ultrasound is usually not indicated for premenopausal women with a normal exam. And she states, premenopausal ultrasound can identify small submucosal fibroids and suggest an endometrial polyp. Also may show PCOS ovarian morphology, helping make that diagnosis.
Yes, and I thank you, Joan. I don't disagree with any of that, but I am trying to think about low resource situations and when patients have high copay, and to say what I think is absolutely necessary in the beginning. But it's true, although I think the saline infusion ultrasound would be much more accurate in terms of submucosal fibroids and polyps. So, we get to that, or we get to a hysteroscopy. So when I think about it stepwise, that was my thought, but definitely can go there faster if you want to.
Could you tell us a little bit more about the saline infusion ultrasound, because I'm not familiar with that?
Sure. So that involves doing a transvaginal ultrasound, but also instilling saline into the uterus through the cervix during that ultrasound, because then you have that fluid around expanding the uterus and defining a polyp or a fibroid. And some GYNs do this in their office, or it can be ordered in many ultrasound departments will be able to do a saline infusion sonogram. I personally was always biased toward hysteroscopy, but there is a difference in opinion about that and what you have available.
That's great. Thank you. Do we have some more questions here? We certainly have time for them. And while I'm waiting for people to enter questions into the chat and Q&A, I just want to remind you that in addition to these educational sessions, MAVEN does electronic consults and also mentoring. But if your clinic would like an educational session, please get in touch with us and we will be glad to see if we can oblige you. We have more than 60 specialties represented in MAVEN, probably closer to 70 at this point. So we offer a wide range of presentations. Here's another question. What is the mechanism of bleeding in the cesarean scar defect? How common is this?
I am not an expert on this, mostly because it wasn't really defined as a phenomenon, probably about the time that I really stopped actively seeing patients, although I had seen it on occasion. I think it is not common, but it is real. I mean, if you look at articles for it, you will find it. And it has to do with the fact that there's like a pocket, there's an actual defect where blood can accumulate, and where there isn't normal layers of myometrium and endometrium, you actually have a defect, and it is diagnosable on ultrasound as a rule.
Hmm.
You also can see it, of course, on a hysteroscopy if you're looking for it, but it's subtle, and it's not at all going to be something that in a primary care setting you're going to jump to. But when nothing else makes sense, you could be a star if you come up with it, because it can be resected and the problem can be resolved.
That's interesting. Thank you. The next question is, how do we prescribe the medroxyprogesterone orally for AUB, the dose and timing?
Yeah, I did. It is on one of the slides there. I'm sorry, I tried to pick it up a little because I wanted to leave a little time for questions, but there are a few different ways to go about this. Probably the most commonly used progestin is medroxyprogesterone acetate. Brand name is Provera. That's usually 10 milligrams. And the duration, you certainly don't want to use it for less than 10 days if you're trying to correct a cycle. But depending on what's going on, if a patient comes in and she's been bleeding for quite a while, I usually give it for at least 21 days, because then they stop bleeding and they have 3 weeks without bleeding, and then they get a withdrawal bleed when you stop the progesterone. So it mimics more a regular cycle, and hopefully it kicks them back into a regular cycle. That can happen because it can just sort of feed on itself, where a patient doesn't have bleeding, the lining becomes thickened, it becomes irregular and uneven. So the bleeding continues and is irregular. And then if you just reset the whole thing by giving progesterone and a withdrawal bleed, you can get them back to where they were. In a really heavy patient, I'd use it BID, just to get more progestin in there. I personally have a lot of experience with norethindrone acetate, which is another equivalent, or a little stronger progestin, and you can give that 5 milligrams BID, and then when the patient stops bleeding, you can taper down to 5 milligrams a day. But the same thing in terms of how long you give it. You decide, where they are in their cycle, or if they're having cycles. So there's some individuality to that. So I think that answers the question.
Great. The next question is, how long can tranexamic acid be used?
5 days is what the recommendation is. So TID for 5 days. So it's really a short term. Although a patient that has menorrhagia every month, you might give it to her. If you've ruled out everything and you've decided that, she doesn't have a structural problem and so forth, you might, or she has fibroids that are not in the cavity, not something that are easily remedied. And this is her only problem, is that her periods are on the heavy side. But if you lighten them up, things are acceptable and she's trying to get pregnant. That's times when you might use tranexamic acid. The only thing that I'd say is you need to take a history about clotting abnormalities in the family. And if you're worried, you need to rule out a thrombophilia before you give somebody the TXA, tranexamic acid. So consulting with a GYN is a good idea.
And our MAVEN GYNs are very available. We have another question. Can you explain how Nexplanon works? Does it have a higher ratio of progesterone to estrogen? Just curious.
Nexplanon is, I'll just stop the share here because I don't think I'm going to be going back on that, and then maybe you'll just see me more. Nexplanon is the progestin implant that's put under the skin in the inner upper arm. And so it's progesterone only. So it's similar to giving the depot medroxyprogesterone acetate. This is again another, if you look at the talks on contraception, it'll go into it in much more depth. But in terms of consistency of levels of progesterone or progestin in the system, the Nexplanon is going to be a better way to go than even the injectable depomedroxyprogesterone acetate, and seems to have less side effects. The oral, of course, is going to be the most erratic in terms of its absorption and levels of progesterone.
Okay, great. I don't see any other questions right now. Any last issues that any of you would like to bring up before we close a little bit early and give you a few extra minutes? Certainly you can get a hold of Dr. Herr and all of us very easily, and we're happy to answer any questions that you come up with later. Here's one more question.
Sure.
Oh, it was a comment. Thank you. This was an excellent talk. Super. Okay.
Thank you.
All right. I don't see any other questions or hands up. Okay. I think with that, you're getting lots of thank yous. With that, I think we'll stop recording and end the meeting.
Okay. Thank you very much. Thank you.